Abby?
Yeah. I literally almost forgot to talk. Shut up. I know.
Good evening, ladies and gentlemen. Abby, can you hear me all right?
Yeah, I can hear you.
Cool. All right. Okay. Okay, folks, I think it's about time to start. So good evening to Anna and Emily and Abby on Zoom. And for those who are here, welcome. And for those who aren't, I hope they get here soon. All right, so we knocked off last time talking about biologics for IBDs, that is inflammatory bowel diseases. And the ones we looked at first were the anti-tumor necrosis factor biologics. And those are used for both Crohn's disease and for ulcerative colitis. And there are several of those. And we saw that those are very effective, but they're also quite expensive. And they're all monoclonal antibodies. And now we're going to look at this one called Ustekinumab, which goes by the trade name of Stelara. Stelara. This one is also used for psoriatic arthritis and also for intractable plaque psoriasis. And I think, yes, it's also been approved by the FDA for rheumatoid arthritis. So this drug gets a lot of uses, Stelara. All right, let's have a word of prayer and then we'll dive right in head first, testing the depth of the water with 2 feet. Father, thank you for this very cold day. We continue to pray for Audrey and her dad. Thank you, her dad is going to get a tracheostomy. Please help him to not get any infections or have any complications. Help him, Lord, to breathe, heal his lungs. Thank you that he's still with us. We pray for Audrey. She must be a wreck. So lift her up, let her know how much we love her, how much we appreciate her and are concerned for her, and we're pulling for her. And now, Lord, please pull us into this subject tonight. In Jesus' name, amen. Okay, all right, anti-TNF. If someone's going to go on an anti-TNF, what sort of things are you going to do? TB test, so the PPD for TB test, excellent. Hepatitis, because these can reactivate. Latent hepatitis B. When you're on these, you will be more susceptible to getting tuberculosis. And if you have latent tuberculosis, anti-TNFs can cause that latent tuberculosis to now become active. And you don't want that. If you have a positive TB test, then maybe you should go through several rounds of treatment, drive it from your body, and then maybe start this medication. Okay, the other thing, you have to teach them how to inject SC. So remember we talked about injecting SC. What are the features about injecting SC? You teach them how to inject subcutaneously. Okay, rotate areas and right, but you inject in the scars? No, 1 inch from a scar, 2 inches from your belly button, navel, umbilicus, whatever. And then do you rub it after you've injected it? Never, 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 never. There'll be a temptation because it'll sting sometimes. You want to rub it. No, 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 don't rub it. Don't rub it. Don't inject into the muscle either. And then make sure you rotate the sites. You guys sound like you have that down. All right. TNFs, anti-TNFs tend to be safe during pregnancy. They tend to be safe during pregnancy. So these are drugs you can give usually during pregnancy. They do cross the blood-brain barrier, the placental barrier, but they don't do anything to the unborn baby. So they're safe during pregnancy. All right. Everybody copacetic with anti-TNFs? Any questions on those? All right, let's take a look at Ustekinumab. So Ustekinumab is a monoclonal antibody against this subunit called P40. P40. So P means it's a protein. 40 means it's a 40 kilodalton protein. That's how large it is. So a Dalton is the size of a hydrogen atom. Kilodalton means it's the weight of 1,000 hydrogen atoms. So 40 kilodaltons means it's the weight of 40,000 hydrogen atoms. Now, P40 is a component of the receptor for two different interleukins, interleukin 12 and interleukin 23. Let me collapse that. There, better? Now, when ustekinumab binds, and that's my very pathetic drawing of an antibody, when it binds to P40, these interleukins cannot bind. If they cannot bind, they cannot induce inflammation. So in this case here, where your ustekinumab is binding, where this is binding, you do not get inflammation. Because you don't get inflammation, essentially, that's the case there, you tend to prevent inflammation in the bowel and places like that. All right, you clear on how ustekinumab works? Any questions about how it works? All right, let's take a look then at the side effect profile of ustekinumab. Usually when you start them on this medication, one of the first things usually you'll see is vomiting. That goes away. Some people can really upchuck quite a bit. So remember, with vomiting, you lose liquid, you lose stomach acid, you lose electrolytes. So you're gonna watch electrolytes, you're gonna watch hydration levels, you're gonna watch, you're gonna watch pH, because you're losing acid. You can become alkalotic. So watch pH as well. Typically not. You can just take blood. Just take blood and run it through the machine. Yeah, yeah. Take some blood, run it through the machine, and you'll know essentially right away. So vomiting usually happens at the first. Some people don't vomit, others puke their guts out. So this one, I would just say, watch. Watch. Because if you lose a lot of electrolytes, a lot of water, that can be something to consider. Okay. Pretty commonly with this medication, you tend to get upper respiratory infections, and you tend to get a kind of nasopharyngitis. That could be because these interleukins may play a role in infections at mucosal surfaces. So you're just more prone to very small infections at mucosal surfaces. Difficult to say, but these are really quite common. So injection site, erythema is pretty common. Even if you have a professional inject it, there's usually some injection site redness. There may be some stinging. Again, tell them not to rub it. It's very, very important. So you may also have, some sinusitis. And in women, you can have vulval candidiasis. And then you can also get some interstitial, misspelled that, interstitial pneumonia. This tends to be non-infectious. It's a non-infectious interstitial pneumonia. Sometimes it's an eosinophilic pneumonia. Those have been reported. Again, you're at increased risk for TB. So what are you going to give them before you initiate this medication? TB test. Hypersensitivity reactions have been noted, so watch the first dose. They should probably have the first dose in the doctor's office, and then they should be watched. Autoantibodies to this do arise, but whether they affect the efficacy of the medication is really difficult to know. No one's really been able to establish that those autoantibodies affect the efficacy of the medication. Now, beyond that, the drug doesn't seem to interact with a lot of other medications. You can combine this medication with corticosteroids. Just like you could combine the tumor necrosis factor inhibitors with azathioprine or with sextylpurine. And you tend to take this medication every 8 weeks. So it's pretty convenient in that regard. You tend to only have to dose yourself once a month. This drug is still under license, so it's way expensive. Eight-week supply is $20,000. It's expensive. Questions about ustekinumab? If it's clear that other drugs don't work and this one does, they will. But you have to prove to them. You have to prove to them. And thing is, you don't pull this on your patient. You don't pull this out of a hat and say, we're putting you on ustekinumab. You systematically try other things. When those other things don't work, then you show systematically, this doesn't work, we go to this. That doesn't work, we go to that. The TNF, anti-TNF drugs, they don't work, then we'll try on ustekinumab. So essentially when they get the claim, they have evidence that this and only this works. Yes, they'll pay the bill. So that's why you have to be systematic. You got to document like a hawk. And unfortunately, the people who read a lot of this stuff won't be doctors, it'll be lawyers. Way it goes. All right. If there are no questions, let's go on to a newer treatment that is kind of taking the IBD world by storm. And that is a drug called vedolizumab. This goes by the trade name of Entyvio. That's a Y, Entyvio. This drug has a very different mode of activity. And here's how it works. So when let's say your white cells, so here's a blood vessel, and let's say here's a white cell. And this white cell wants to get out into the tissue here. Okay, so you guys already know I'm a lousy artist. So in order for this white cell to get through here, it has to attach to a specific integrin. And that attachment with that specific integrin is going to cause the endothelial cells to essentially step aside so the white cell can squeeze through. And this particular integrin is called alpha 4 B7, the alpha 4 beta 7 integrin. So vedolizumab binds to that integrin and basically tells the white cell to take a hike. So the white cell stays in the bloodstream. The white cell cannot get out here and cause inflammation in the bowel. No white cells in the GI tract, no inflammation in the GI tract. So your general immunity stays the same. You're not prone to bad infections, but you keep the white cells out of the bowel and you decrease inflammation in the bowel. Pretty nifty, huh? So think of this kind of as a door. And this integrin is the key that unlocks the door. Essentially, this antibody plugs up the lock so that the key can't be inserted and it can't open the door and this can't admit itself to the GI tract. Right? Make sense? Some of you are writing furiously, but no questions make it look seem to me that you do understand. Okay, this has been approved for use in both Crohn's disease and for ulcerative colitis. And it is used when your corticosteroids, immunosuppressants, or your TNF inhibitors have not proved effective or they've proven intolerant. In Crohn's disease, essentially, excuse me, by week 6, 30% of the patients are in remission, and by week 52, 40% of patients are in remission. With ulcerative colitis, by week 6, half the patients are in remission. And then that half stay in remission by the time you get to 52 weeks. So this medication is relatively effective for certain patients. Okay, so once again, you're susceptible to tuberculosis. So your tuberculosis risk goes up. So again, give them a TB test. Also, there are reports of increased risk of meningitis. Now, that risk increase is not huge, but there's definitely an increased risk. What are the signs of meningitis that you tell your patient to watch for? Sorry? bad headache, stiff neck, usually a fever. That's kind of a classic triad. You may also have visual disturbances. You may also have behavioral changes, things like that. But these usually, this triad here, fever, a bad headache, and a stiff neck, that usually, if you see that, they should probably check themselves into the emergency room. Okay, so that is vedolizumab, essentially. This is also injected subcutaneously, so you have to teach them all about injections and what have you. And vedolizumab is, you inject it every 8 weeks, and an 8-week supply of vedolizumab. Oh, excuse me. This is not SC. My bad. My bad. This is IV, so they have to come in for this one. Cost of 8 weeks of vedolizumab is $6,000. Then, finally, there is an oral treatment and this oral treatment is a JAK kinase inhibitor. Now, you're probably thinking, JAK kinase, what on earth is that? So this stands for the Janus kinase, and that's the reason why it's called Janus kinase. So this is in your immune cells, when these cells receive a signal from a cytokine, they bind to their cytokine receptor like that, and then they send a signal into the cell. And part of the system that relays that signal into the cell is this Janus kinase, this JAK protein that's inside the cell. And it's associated with the receptor. And if you hamstring this, the immune cell doesn't get activated. So you essentially quell inflammation. So that's how this works. So this particular drug is called tofacitinib. Now, we'll talk a bit about anti-cancer drugs, NIB. When you say NIB at the end of a drug, that means it's an inhibitor, usually of a kinase involved with cell signaling. So that NIB at the end tells you it's a kinase inhibitor. So tofacitinib, this goes by the trade name of Xeljanz. This is oral. And this, of course, is used if you failed lots of other things. This drug, unfortunately, has a lot of side effects. Let's talk about the adverse effects of this drug. There are quite a few. Once again, increased risk for infections, Once again, our old buddy here, TB risk. So do they need a TB test? Yes, they do. You also tend to see things like a rash, upper respiratory infections, just like with Ustekinumab. And then, of course, headache, nausea, vomiting, diarrhea, just NVD. You can have some increased levels of creatine phosphokinase. What's this protein do? Creatine phosphokinase. Any of you remember? So what does this molecule do? What's that do? Energy. In muscle, you have a reserve energy molecule called phosphocreatine. And so creatine is phosphorylated by ATP to make phosphocreatine. That's your reserve. That helps your muscle recover after you use it. So when Clarissa goes and works at the gym so that her bowling delivery is flawless, and she works really hard and she gets really tired, is she tired for the rest of the day? Clarissa, don't let me down here. No, she can still go to the DC and do this with a fork. Her muscles aren't so shot that she can't do that because she has phosphocreatine. The enzyme that makes phosphocreatine from creatine is creatine phosphokinase. So if this is leaking into the blood, it tells you you have muscle damage. This is a marker for muscle damage. And then you may also have lymphopenia, neutropenia, hence that explains the increased risk for infections. So your lymphocytes, you're going to monitor lymphocytes every 3 months. Monitor lymphocytes every 3 months. Also, your risk of malignancies will go up. And this drug is also metabolized by cytochrome P450-3A4. So you cannot mix this with strong inhibitors or strong inducers of 3A4. So make sure you check for DDIs. And then again, the other thing they can't have with this is grapefruit juice, since grapefruit juice inhibits 3A4. Okay, any questions about tofacitinib, excuse me, Xeljanz? This drug's got a truckload of side effects, so helping your patient manage the side effects can be a real challenge with this medication. Some people get a new lease on life on it, but usually they failed everything else. Just one other thing about IBD's Crohn's disease, but not ulcerative colitis, can be treated with antibiotics that usually includes things like metronidazole. We talked about metronidazole and the things you have to be concerned with, and then ciprofloxacin is another one that's used for patients. This is especially important if they get some sort of outcropping that gets infected. So it's sometimes called a pouchitis. They get a pouchitis. That's especially the case if you follow a colectomy or, whatever. Probiotics, on the other hand, probiotics have been studied. They might help ulcerative colitis. They definitely don't help Crohn's disease. Some people can actually push their ulcerative colitis into remission with probiotics. That group is a minority, but it can happen. Crohn's disease, probiotics, no, nothing. All right, are there any questions about IBDs, treatment of IBDs, any of the drugs we've gone over? You have any questions about? Okay. Soldier on. Okay, let's now, finally, for our GI stuff, talk about antiemetics. So some of the treatments that patients will undergo will cause them to have an unsettled stomach. And so often you'll be called upon to deal with someone's sickness due to anesthesia, or sickness due to chemotherapy, or sickness due to whatever. So that's essentially the domain of the antiemetics. So these are anti-nausea medications. Anti-nausea medications. So for chemotherapy-induced nausea and vomiting, one of the best medications is dexamethasone. That's used quite a bit. That's, of course, a steroid. That's usually administered orally, but it can also be administered intravenously. Now, just a quick reminder, in the brainstem, so it's near the so-called tractus solitarius. Just dorsal to the tractus solitarius, you have this group of neurons. So let's just say dorsal to that. This group of neurons are called the chemoreceptor trigger zone. Receptor trigger zone. This gets abbreviated CTZ. So the CTZ is going to use the neurotransmitters dopamine and serotonin. And this is going to connect to the so-called vomission center. And the vomission center is ventral to the CTZ. But these are all in the medulla. So if you block this signaling from the CTZ to the vomission center in the brain, and this is why if you eat certain things and they're off, that's a British term. They're spoiled, sorry. They're spoiled. Caught myself right when I said that. You ever heard that term, your food is off? No, yeah, it's a British term. If your food doesn't quite taste, if the cook messed it up, your food is off. But if it's spoiled, it's off. So if you watch Masterpiece Theater sometimes, dear, smell this. Is this off? They mean is it spoiled? I'm sorry, I still talk that way. Yeah, they'll say it tastes off or it smells off. It's used, well, for smell and taste. Anyway, this is the reason why some foods will just cause you to upchuck, because they have chemicals in them that activate this chemoreceptor trigger zone, which then stimulates the vomission center, and out it comes. And that's essentially what certain procedures and certain chemotherapeutics will do to you. So some drugs are going to inhibit the signaling from these two neurotransmitters. And that's how they're going to prevent either postoperative or chemotherapy-induced nausea and vomiting. Okay, so there's a group of compounds that are going to block a neurotransmitter called neurokinin. These are neurokinin receptor antagonists. And there's a group of these. The one that gets used a lot is aprepitant. Aprepitant. Aprepitant goes by the trade name of Emend. There is a prodrug of aprepitant called fosaprepitant. This is for intravenous administration. Then there is a combination drug that we'll look at a little bit later. So again, these are for usually delayed nausea and vomiting secondary to chemotherapy. So these are usually used for chemotherapy-induced nausea and vomiting. So these drugs will cause asthenia. They can cause dizziness. If your patient's older, this could be a fall risk. So what do you do if a patient's a fall risk? The belt, right. Most places it's white. Other places I've seen it different colors, but most places it's white. You get the white belt out and you hold on to them while they walk. And if you feel them going, and if they're a big person, you do it all yourself? No, the H word, you ask for help. You ask for help. That's why nursing is a collaborative enterprise. The other is hiccups. Strangely enough, hiccups. There's fatigue as well. And then your liver function tests, you'll see those get elevated. These drugs interact with, so they have DDIs with warfarin and oral contraceptives. That's your neurokinin receptor antagonist. Next, you have the serotonin antagonist, the serotonin receptor antagonist. Now, as we're going to see when we get to the psychiatric drugs, there are a lot of serotonin receptors. They all have different functions. So with these particular group, they are so serotonin is often called 5-HT, 5-hydroxytryptamine. This is a 5-HT3 receptor that they antagonize. That's significant because that's the one that tends to lead to vomiting and nausea. The big drug in this group that's used a lot in hospitals is ondansetron. This goes by, I'm sure you've heard of this drug, Zofran. Yeah, okay, I see a lot of heads nodding. Zofran. In fact, most clinicians just call it Zofran. All the other drugs in this group end with cetron. Cetron. So there's grani, cetron. There's palano, cetron. There's dol, cetron, and what have you. Okay, this drug ondansetron, it elongates the QT interval. So, what are you going to be checking when they're on this drug? EKG. And you're going to check their med chart, see if anything else is on there that increases the QT interval. Because remember, drugs that increase the QT interval, they tend to do so additively. And if it gets too long, over 250 milliseconds, you're at great risk for torsade de pointes. So EKG that puppy. Well, that patient. On the average, these drugs are pretty well tolerated. However, they can cause dizziness. That tends to be the case more in elderly patients than in younger patients. They can cause diarrhea. Some people get a headache. Some people get a fever. Those are fairly low percentage events. Others get constipation. People who take these drugs tend to have had procedures, so these things might be due to the procedures. And then some get drowsiness, which in some cases might actually be a blessing because it'll help them sleep. But the biggie, of course, is the QT interval elongation. All the agents that I talked about here, ondansetron, granisetron, polonositron, alosetron, all of those have equal efficacy. These also play well with other drugs. You can combine them with other drugs. In fact, the polonositron that particular drug comes in a combination with a neurokinin receptor antagonist. This is called metopitant. This combination is called Akynzeo. And that is a very effective treatment for chemotherapy-induced nausea and vomiting. Now, oh, wait, questions? You guys have probably administered Zofran, I'm betting. It's used a lot, Relatively inexpensive, pretty well tolerated, works pretty well. Let's go ahead and take our break now. We'll finish this and then we'll jump into the drugs for the reproductive system. Did everybody get the handout I mailed you? I discovered the other handout I sent you, I already sent you. So, oh well. Doubling up on handouts never hurt anybody. So, way it goes. Okay, let's take 5 and then come back and we'll finish this up. Guys are all so quiet tonight. Sometimes I get the feeling your Tuesday clinicals just wear you out. Since you're probably all wondering what this is, I'll just tell you. I had a fingernail biopsy. So they had to pull the fingernail off. So that's why it's all wrapped up. I had a dark stripe. It wasn't dark, it was kind of off color. And my dermatologist said, I have no idea what it is. Best way to tell is to just biopsy it. I said, is that your recommendation? She said, that's my recommendation. So I went to Michelle Aubin, the hand surgeon specialist, and she did the biopsy. And yes, it hurts. It hurts. They gave me Norco, and I'm really trying not to take it. So if I sit there and do this, you know why? Because it stings. Okay, people. Not a normal looking EKG. So I had to drive in the snow yesterday. Yeah, it was pretty nasty. It was pretty nasty. All right, it's time to resume. Now, since some of your antipsychotics do such a good job at blocking dopamine receptors, you actually have antipsychotics that are used for simple nausea and vomiting, or they're used for mildly emetogenic doses of chemotherapy. So these include some of the first generation antipsychotics. They tend to be used in very low doses for this. So there's chloropromazine. And that is in a generic, but because it's known so well by its trade name, it still gets called thorazine. Then there is perfenazine. And that is known as trilofon. Then there's prochlorperazine. That gets called compazine. And then there's promethazine. This is the one that's probably used the most, promethazine. That's the one that's called Phenergan. That is probably your most heavily used out of these. So these block dopaminergic receptors. They block dopamine receptors in that chemoreceptor trigger zone. Because they block dopamine receptors, and because dopamine plays a role in voluntary motion via the nigrostriatal dopaminergic system in your brain, these can cause movement disorders. In the low doses in which they're given, they don't tend to do that, but if you give them to some people who are sensitive to them, you will get so-called extrapyramidal reactions. Extrapyramidal symptoms so these are movement disorders. These are tics. These are uncontrolled movements, things like that. And if you give them for a long period of time, they can affect the bone marrow. They can cause aplasia of the bone marrow. If you give somebody a one-shot dose of Phenergan, that's not going to happen. But long-term, that is a possibility. They can cause sedation. In some people, the sedation can be pretty robust. And they can also cause cardiac arrhythmias. And I misspelled that. And some of them even can increase the QT interval. If they start getting extrapyramidal symptoms, you give them diphenhydramine. Diphenhydramine will block the muscarinic and histaminergic receptors that connect to the inner ear and the vestibular center. And that essentially will prevent this sort of thing from happening. You can also use pro-dopaminergic drugs like benztropine. That's a Parkinson's drug. That's a dopaminergic drug. You can use that too. That's a possibility as well. Hypotension can be a concern. So watch the blood pressure because the blood pressure may drop. So you're going to watch blood pressure. Make sure that your patient gets up, sits down carefully, slowly. And since there are sedative properties, you don't want them to be doing anything that can cause sedation. Some of these also have anticholinergic effects. So those anticholinergic effects can be dry mouth, urinary retention, and constipation. So have them increase their fluid intake and their physical activity. For dry mouth, they can suck on hard sugarless candy or chew gum. That will help with the dry mouth. You can use laxatives like the ones we talked about. You can use decussate, or you can use senna for the constipation. You're going to want to palpate the lower abdomen every 4 hours to make sure that the bladder is not holding liquid, that you don't have a bladder that feels like a big inflated balloon. So they should void every 4 hours. All right. Then you have cannabinoids. These drugs are derived from cannabis, otherwise known as marijuana, reefer. Right. So there's dronabinol. This goes by the trade name of Marinol. And navalone. That goes by the trade name of Tesamet. These are very good if you need a patient to increase their appetite. Cancer patients sometimes, the cancer produces molecules that suppress appetite. And if they don't eat, they're going to undergo cachexia. They're going to shrink. Dronabinol in particular is very good for that because one of the side effects of this is increased hunger. So this drug gets used a lot for cancer patients who are not eating. These drugs can cause hallucinations. They can cause euphoria. They can cause sedation and vertigo and time distortion. And they have a degree of dependence. So these tend to be used if it's a cancer patient, so what? If it's a patient, say, who's having chemotherapy and they're getting sick, this essentially be your last resort. You also contraindicated in people with mental disorders. You'll make their mental disorder worse. Distortion. Vertication. Memory loss. You may have some patients, you may have fear or even confusion. Some people will get anxiety. You can also get mood changes. Sometimes those mood changes are good because if the patient's depressed, this might be a little pick me up. Okay, another group of drugs you can use, usually for nausea and vomiting as well, are the benzodiazepines. And the benzos you're going to use. So benzos are normally used for anxiety. Thing about benzos, you can get hooked on them. So you always want to try to use benzos short term, typically. But for these, the best one is the long-acting ones, lorazepam and diazepam. Diazepam goes by the trade name of Valium. Then lorazepam, that's one that gets called Ativan. These can make you stoned. Sedation in elderly patients, they now become a fall risk. That's especially the case in the elderly. They can also cause retrograde amnesia. Sorry, antegrade amnesia. These are especially good if the vomiting and nausea is caused by anxiety, because these treat both the anxiety and the nausea in that case. And again, you can treat two things with one drug, do it. Do it. Valium, the diazepam, is a muscle relaxant, so you'll tend to be really relaxed and what have you. Okay. I think that is all of that. There are, oh, you know what? I forgot to talk about that, didn't I? I forgot to talk about irritable bowel syndrome, didn't I? Did I talk about that last time? I don't think I did. So, Irritable bowel syndrome, very fast. You can have irritable bowel syndrome characterized by constipation. You can have irritable bowel syndrome characterized by diarrhea, or you can have irritable bowel syndrome characterized by both constipation and diarrhea. It's a mixed condition. So the big characteristic of irritable bowel syndrome is that you tend to have spasms. Spasms in the bowel. So that smooth muscle, again, for reasons that are not understood, tends to just spasmodically contract, and it can really hurt. So definitely the drugs of choice for these spasms are a couple of drugs. There's a drug called dicyclamin. This is in generic, but its trade name, if it is under trade name, is called Bentyl. And then there's hyoscamine. This goes by the trade name of Levsin. These are meant to be used on a PRN basis, and these have anticholinergic effects. So all the things associated with anticholinergics, dry mouth, visual changes, tachycardia, urinary retention, decreased sweating, so you tend to be very hot, blurred vision, sedation, dizziness. Those are all the effects of anticholinergics. Now, if you use this with another anticholinergic, their effects are additive. So check their drug chart. Look for other anticholinergics. If you see other anticholinergics, you might want to try something else. These are very good at dealing with the symptoms. These tend to come as liquid. You tend to take a swig, essentially, of a certain amount of it. Okay, let's talk about IBS-C. So there's two drugs that are used for IBS-C. There's a drug called lubiprostone. This tends to be used only in women, simply because in the clinical trials, women had a definite benefit from it, whereas men did not have a clear benefit from it. So it tends to be restricted to women in its use. So this is a prostaglandin. It activates chloride channels in the GI cells. That essentially is going to stimulate intestinal fluid secretion. And that is going to distend the bowel, increase motility, and increase transit time through the GI tract. So the two main side effects in this are going to be nausea also a headache, and as you might guess, since it'll treat constipation, diarrhea. Tends to be very effective though. So this is kind of a laxative effect. Now the next drug that is useful in both men and women are two related drugs, linacotide and another drug that's actually more effective, plecanatide. So let's see, this goes by the trade name of Lensis. And plecanatide goes by the name of Trulance. These are going to target guanylate cyclase. That's going to increase your cyclic GMP levels inside intestinal cells. That is going to increase intestinal secretion. So it works kind of similarly to lubiprostone in that your readout is the same, but it is going to increase your intestinal transit time. So these can cause abdominal pain, they can also, of course, cause diarrhea. Other than that, they're fairly well tolerated. If you take it with food, that tends to decrease any feelings of nausea or something like that. Okay, now let's discuss drugs for those for the diarrhea characterized IBS, and then now let's do D. So the first of these is a drug, again, that's only used in women, and that is alosetron. And yes, that ending should look familiar. And this is also a 5-HT receptor antagonist. This is a drug that is called Lotronex. It was pulled, then it came back, it was pulled again, now it's back again, but it's only to be used in women. This drug will cause constipation, nausea, may cause also some GI discomfort. And more serious issues, it can cause ischemic colitis. That would be, that's rare. And this is only to be used in women who failed more conventional treatments. The other treatment that's used are, believe it or not, antidepressants. Because some of these antidepressants have a side effect, diarrhea. Sorry, constipation. So why not use them for diarrheal diseases? Makes sense, I suppose. And so this includes the SSRIs and also the tricyclic antidepressants. The evidence base for these is poor. frankly, when it comes to diarrhea, bulking up your food with fiber and things like that can actually do wonders for you. So that's why there are fewer drugs for that than there are for the constipation one. All right. I think that's everything. Oh, that's a lot of drugs. Okay. Take a nice deep breath. In, out, in, out, in, out, in, out. Let's talk about drugs for the reproductive system. If you have your handout that I sent to you, please get it out. Let's take a look at the drugs for the male reproductive system first. So the first of these is going to be testosterone. So testosterone comes in a tablet that you take orally. It also comes in buccal strips. Comes as a gel, comes in a patch, comes in lots of different shapes and sizes. So what's it used for? It is used to treat certain breast cancers. And it's also used in guys who have hypogonadism. What's hypogonadism? That simply means the sex organs are underdeveloped. The sex organs are underdeveloped. So with testosterone, you will get increased growth and development of the male sex organs and secondary male characteristics. You will also get increased retention of certain minerals like calcium and phosphorus and potassium and sodium and nitrogen. So you get retention of, let's call them elements. You get increased protein synthesis. You put on muscle. You get decreased protein catabolism. You get increased numbers of red blood cells. So they're good for anemia and what have you. Oh, they also come in IM injections as well. Sorry, I didn't mention that. So one drug, it's at, I believe it's at the top of your list, is called danazol. Yes, do you see that? So danazol is used to treat endometriosis in ladies. And it's also used to treat fibrocystic breast disease. And it does this essentially by inhibiting gonadotropin releasing hormone. That leads to a decrease in your gonadotropins, like follicle stimulating hormone and luteinizing hormone. Because you have a decrease in the gonadotropins, you'll have a decrease in the cycling of this tissue, this uterine tissue that's stuck to other organs that tends to cycle and bleed. So that is danazol, that's what that's used for. So this is largely going to be used in gals. Now, testosterone is a very powerful medicine. Not a medicine and medicine to be taken lightly. Lots of contraindications to it. First of all, hypersensitivity reactions. Two, probably something in the preparation has been reported. So hypersensitivity. Hypersensitivity has been reported. How do you head this off the past? Test dose. Give them a test dose. If they tolerate the test dose, they will usually tolerate the larger dose. So give them a test dose. Okay? Secondly, you don't give it to people who are pregnant or who are lactating. It'll have adverse effects on the neonate. It's not terribly clear if androgens enter breast milk at high levels, but because they can have pretty, even small levels, can have pretty profound effects on neonates, it's just contraindicated overall in cases like that. Next, if there's prostate or breast cancer in males, you don't use it, it'll make these cancers worse. If you have liver dysfunction, you need a liver to be able to metabolize and eliminate testosterone. Also, if you have cardiovascular disease, that's a big, big contraindication for testosterone. In fact, testosterone topical forms have a black box warning due to the risk of virilization in children who come in contact with the drug either by touching the skin of someone who's put it on their skin or by touching the clothes even of someone who's had a patch. And then for danazol, danazol has a black box warning for thromboembolic events. And also fetal abnormalities, so and so on and so forth. Okay. So what sort of adverse effects can we expect from testosterone? Quite a few. First, acne. Second, you're going to retain fluid, edema. Then you're going to have increased hair growth. Then the voice is going to deepen. You also get oily skin and hair. You'll typically also get weight gain. breast size is going to decrease. And in guys, because it inhibits secretion of gonadotropins, you get testicular atrophy. In women, you will get usually anti-estrogen effects. So you'll get everything from flushing and sweating, just like you're going through menopause. Vaginitis, usually because the birth canal just becomes very dry, usually nervousness. Emotional lability. You may get a headache. This is usually due to fluid changes. Dizziness. Sleep disorders are pretty common. Rash, sometimes fatigue, and then altered serum electrolytes. And you're at increased risk for hepatocellular cancer. So, someone's going on testosterone. Usually you're going to see decreased thyroid function. And you'll also see increased creatinine, and then also creatinine clearance. This can continue even after 2 weeks after the drug is discontinued. That's not a disease state thing that you expect that. Okay, what's the nursing responsibility? If someone's going to go on testosterone, you must get a baseline to compare them to. So you need a complete physical exam, mental status, skin assessment, abdominal exam, before you start drug therapy in order to determine the effects of the drug. You'll need x-rays of the long bones to assess the effects of testosterone on growth, and then assess for complications or contraindications to prevent any sort of issues. You want to monitor the response to the drug carefully at first so that the dose can be adjusted. Patches, remember, always remove patches before you have an MRI because there's metal in the patch. Patches should be taken and you take them and then put them together and then flush them. Don't put them in the trash. Monitor liver function regularly. Discontinue the drug with any sign of liver dysfunction. And then essentially evaluate based on the effects of the drug. And we're out of time. Okay, one thing before we knock off As you may have noticed, we're getting close to the end of the semester. And as you may have noticed, I'm way behind. So I'm going to have to simply do some podcasting, just so you guys can get at least exposure to the drugs. We're just not going to have time to cover it. So I am of the opinion, and I'm of the opinion even more now after this semester, that this class really needs to be a combined online and in-class class, where some of the stuff you get via podcasts, others you get in class, because there's just too much stuff to cover 3 hours a week. It just can't be done unless I run through everything and don't give you any details and then leave you going, what? How does that work? Well, people who say, what? How does that work? Tend to not pass the NCLEX. Now, some have complained I give too much detail, but guess what? Too much detail gets you a better NCLEX score. That's what it gets you. So I am giving you your money's worth. So stop complaining. No, I'm not saying you're complaining, but anyway, you'll get some podcasts for you to view. I don't know when I'll do them, but it'll be before finals. Okay? All right. See you guys next week. Yeah.
What do you like about metformin being used off label for